So we're going to switch gears here in a way, but I think this really follows on what we've talked about, and that is the fact that if you're a caregiver for dementia, a person with dementia, you are already in part a surrogate decision maker. That is, you're helping make decisions for that person. Okay. Now, just a couple, you'll see I'm big on definitions here. A couple background definitional ideas. Some scholars talk about the fact that competency is a legal term, and that what we call capacity is a more medical term. And they try to use those words, they say we should use them differently, that ultimately only a judge can say that someone's incompetent. That's true. And it is the clinician who says this person has the ability, the capacity to do this and lacks it to do that. In the real world, judges, lawyers, doctors, psychologists, they use these words interchangeably. And that's the real world. So, but it's useful to keep in mind, and it is very important, that each and every one in this room is fully competent, because the minute you reach the age of majority, 21, 18, differs by state, 16 now some places, just being an adult means you're fully competent, right? And in our country particularly, where we have a strong emphasis on individuality and individual rights, that means that we make decisions for ourselves. And we all automatically have that competency unless it's been taken away, adjudicated by a judge. So that's sort of where we start. Now, the reason I say, even though we use these words interchangeably, it's useful to keep in mind that until the very present, and actually I think George is leading the way on this, but that competency is basically, in the past, has been a yes-no decision. You got it or you don't. We all have it. And in the past, a judge would say somebody's incompetent. Whereas from a capacity point of view, you might say, you know, your memory is not quite as good as it used to be. Okay? Or your ability to use language and express yourself is a little lower or a lot lower than it used to be. So we call that a graded or dimensional feature. That means that these mental abilities, it's like they're on a line. Some people are 100% where they've always been. There are unfortunate people who are really at zero, who absolutely lack it. But there are people in between. And if you get back to what I was saying about our goal in caring for people with dementia is maximizing their function. In a sense, what that really means is we want to find out what's a person's current memory ability, current language ability, current decision-making ability, and allow them to function at that level. And the neat thing, I think, with the Georgia law now and the clinical approaches, we've come together on that fact. And this is not true in most places. Okay. So there are different ways that people define competency, and I have my own way of doing it. I'm a stubborn person, and so nobody else uses these words, but in a way. But I think there are three, when we're thinking about whether a person has competency or capacity, we really are thinking about three issues. So let's say someone's facing a choice. To make it really simple, I believe that all we require is that, number one, the person understand what the choice is. They have some idea of what's going on. They need an operation. They need to sign to sell their house. Okay, so they have to understand what the issue is. Number two, they have to make a free choice. Okay, that doesn't mean Dad, you want to sell the house, right? That's not making a choice. Okay. What do you want to do about the house? So the person might have to remember that there's a question about selling it and say, I want to do it. Simple, I think. Okay. Coercion-free, that's where that, again, it's not always coercion where Dad, you want to sell the house, right? But that's really what it means. Now, many people believe that there's a fourth element in here, and that is the person has to be able to justify or give a reason for their choice. And I don't think that's required. If someone says, it's none of your business why I want to sell the house, it's what I want to do, we let them do it. Now, if they can say, I don't need a 4-bedroom house anymore, I'm downsizing, we feel that makes us feel they're making a choice there. But to require that, I think, is a mistake. And many of the experts include that as one of those criteria. So that's just a quibble. All right. This isn't on your list, but I wanted to add this. It's not in your slides. I just added this because we do, even in medicine and psychiatry, we have some things that we operate more in this yes-no function and more in this graded function. So what we used to call mental retardation, which is now called intellectual disability, or personality problems. These are dimensions of life, right? There are geniuses, and there are some of us who are not so smart, and most of the people we know fall somewhere. There are lots of people who have better memory than I do, and there are a few that have worse memory. My wife will tell you that. I'm totally absent-minded, and I've been that way my whole life. We all fall on these dimensions. That's part of normal life, and the question is, who is that person and what have they been their whole life? But there are diseases that, in a sense, change people. And so dementia, and schizophrenia, and even severe depression, we think of more as you have it or you don't. And I mention that because when we want to come back to this question, does somebody have limited competency due to an incapacity? The doctors has to do two things. Number one, say here is what their capacity is, or here's where it's limited. But number two, they have got to give a reason. So a reason is not, well, he's never been good with money. That's not a medical condition. So the reason medical people, psychiatrists, psychologists, and in many jurisdictions, social workers are involved is because we have an expertise, not just in measuring somebody's memory or whatever it is, but we are required to make a diagnosis. That is, we have to say it's due to X. And without that, I don't believe we can say someone has a newly imposed limitation on their ability. So that's a little technical, but okay. All right. So when I'm asked to evaluate someone, is this person competent to sell their house, sign a contract, write a will? Okay. Again, because everyone is competent until otherwise designated, my focus from the doctor side is I want to know, do they have new impairments? Do they have impairments? Now, they could be lifelong and they've never had the ability, but we're putting that aside here, okay? And as I said, the clinician needs to make a diagnosis, has to ascribe it to a disease. This is often where doctors fall apart. They say, well, this is stupid, or anybody who has gangrene should have their leg cut off. And you say, well, this guy doesn't want his leg cut off. You say, well, that doesn't make any sense. He could die from it. And you say, okay, so what's the disease that's making him make that stupid decision, doctor? You say, he's just stupid. I'm sorry. That is not a disease. You don't like his decision, doctor. That's not a medical reason for saying he lacks the ability to make that decision. Okay. Another question is the impairment permanent or progressive? So there are medical conditions that are transient. There's something called delirium, which is very common in the medical hospital, in which people acutely, suddenly become thinking impaired. But when the medical condition gets treated, they're back to normal. All right? So if the question is, should somebody sell a house? The right thing is to say, this person can't make that decision today. When he's recovered, and he may well recover, you can revisit it. So if it really looks like it might be a non-permanent condition, you want to do everything you can to put that decision off. Now, if it's a medical emergency, then this person might be temporarily unable to make that decision, temporarily incompetent to make the decision to have surgery. Due to, in that case, it would be delirium. But these are there aren't that many things in medicine beside emergency surgery that have to be decided right now. Very few. Okay? The hospital says we need to decide whether to put a feeding tube in. Not an emergency. Period. And they don't want to keep the person? Tough luck. You think it needs it? They're staying here until we carefully assess it. All right? Now, when we're trying to assess a person's capacity, and they say, well, the doctors want to do surgery. The doctors want to cut my leg off, so they understand the issue. It does strengthen the case that they're making a decision if they can tell us, again, not just the reasons they're doing it, but what are the harms and the benefits. So if someone said, the doctors want to cut my leg off, and you say, well, if you refuse, what could happen? And they say, the doctor said I could die. Again, right there, the whole question, the person knows the worst thing that could happen, then as far as I'm concerned, they have capacity. Okay. So when people say, well, I don't know what could happen, then we have to delve a little further into it. Okay. The reason progression is important is particularly in something like Alzheimer's disease, we have to realize that a person may be able to make certain decisions now, but a year from now may not be able to, and it may need to be revisited, and everyone needs to know that. Okay. And I've sort of covered these last ones. Okay, so that's just a little background here. What I thought would be useful is to go through 6 or 7 challenges that come up in the care of people with dementia and tell you at least how I think these through, with the idea that maybe by thinking through real life examples, we can sort of figure out what are the principles that we're using to make decisions. Okay, so let's start kind of at the beginning in a way. You're worried about your loved one who has a memory problem, and they don't want to go to the doctor, right? And, this is your dad, your mom, your spouse, whatever. So you care a lot about them. You heard Dr. Rabins. He said, you got to go to the doctor. You don't make the diagnosis on yourself. How do we think that through? What's okay? Whoops. Help. Oh my goodness. Okay. Oh, there it is. It skipped it. Okay. So number 1, we have to keep in mind, we do not force medical care on a competent person. Most people in which this comes up, we're concerned that they're forgetful, still have a significant amount of decision-making capacity, even though, as someone mentioned in the back and asked that question, they may not have full insight into the fact that they might have a memory problem. Okay? So then we have to ask, in a sense, let's just say they don't really realize they have a problem. How then the question is this really dangerous? Okay. Is something bad going to happen soon if they don't get evaluated? And the truth is, usually in dementia, a week or a month or 3 months isn't going to make a big difference. Right? Okay. So since we can't force care on people, going a legal route, forcing somebody to get evaluated for dementia against their will really violates this usually, and without a dramatic benefit. Now, does that mean we can't say, Mom, I would feel better? Or ask them every week or month? Or say, I know you don't, last month you told me you didn't want to go to the doctor, but would you do it for me? I'm so worried. Or, as I mentioned to somebody in the break, I hope you're right, and if we go see Dr. X and she tells us your memory's normal, I'll feel embarrassed, but I'll feel a lot better, and I'll tell you you're right. So this is where getting somebody evaluated in most situations for dementia, unless it's pretty advanced, or there's some life-threatening issue, we're not looking for some kind of legal solution here. We're looking for an interpersonal solution. And often over time, not always, often over time, we can somehow get the person to the doctor. And if it's the routine visit, you want to make sure you call the doctor ahead of time and say, I'm really worried about my mom's memory. Will you evaluate that as part of seeing her today? But please don't tell her I said anything, and the doctor may or may not do that. All right. So unless here I think it's clear, unless there is clear evidence of danger, someone has some new very severe medical problem, you're really worried about it, and you think they're not acting on it, and for some reason you think they have chest pain and they won't let you call 911, you call 911 anyways. Okay? When there's real evidence of severe danger, then you act. Otherwise, this would be a situation where we ease off. How about the person who lives alone and has memory trouble? Believe it or not, 20% of people with Alzheimer's disease in the United States live by themselves. 20%. Now, they have milder disease than the group as a whole, but often individuals living at home, they're losing weight, the house is a mess, etc. Okay. Again, the first question is there real concern, and the person says, I am not moving, I'm staying here the rest of my life, this is my house, I won't go. I think, again, we have to fall back on, is there a clear danger here, either to that person or their neighbors? So they live in a connected house or in an apartment, and the place is filled with garbage, and there might be a fire hazard for other people. That presents a danger to someone else, and that's the kind of situation where the Agency on Aging might force somebody to be evaluated. Okay? But there has to be a real reason to think that there might be danger. Second, again, like with the evaluation, be persistent. They might not move now, but maybe over time you can win them over, keep talking about it, nag them. Sometimes you can get people to clear. If danger is clear and the person absolutely refuses, then we have an obligation to protect them. So this is the tightrope. This is the tension here. We have an obligation to protect the infirm, on the one hand, the really infirm. On the other hand, we have an obligation to protect people's independence and right for self-determination. This is the tension in our legal system. And we're not going to force people to do things for minor reasons. So we have to have a pretty high concern for danger before we're going to restrict somebody's rights of where they're going to live. All right? Now, sometimes if you give people a set of options, but they're limited, how do you convince people to do something that they might not want to do? Okay. Sometimes you can say, look, Mom, there are 3 choices here. You can move to Billy's house, you can move into this senior apartment, or this assisted living. You can choose. Okay. But living alone, you don't say living alone isn't one of them. And again, sometimes you can kind of convince the person that they're making a choice. So here I think the principle is, as in all of life, we want to maximize the person's choice if we can, but we are obligated to protect the very clearly impaired. So there has to be convincing evidence. And again, you might need a professional to determine that. Okay. So these are tough situations, because when you care about someone, when you love them, you want them to be evaluated. You don't want them to live at home when they can't use the microwave anymore and all they can do is boil hot dogs and eat toast. But if they're getting along and they're taking their medications, and doesn't mean you have to abandon them, but try not to set it up so that it's either you move or I don't come visit you anymore. You hang in there and hope that over time you can convince them. And often, not always, but often you can. All right. Now, these get tougher. Okay. So I talked a little bit about driving already, but the person who demands to drive. Oops. I have to be patient with this clicker here. All right. Okay, so I've already said we do not have research to know when someone should stop driving. This is kind of sort of the reality. Everybody's paging. Does that mean you don't have these pages? Or? All right, sorry. I'm not sure why it's not there. Okay. But here, this is different than those first circumstances. Okay. Number one, driving is not a right, it's a licensed activity. But number two, it places other people at harm. All right? And so the calculus changes a little bit here, and we let the Motor Vehicle Bureau decide that when somebody fails a test or whatever it is, they can summarily say you can't drive any longer. And it also means that we as caregivers then, if somebody's driving and we have a concern, we have some obligation to report them, I believe. We have an obligation to our loved one, but we have some obligation to society in general. And for driving, because it really does put other people at risk, I believe that as caregivers, we have an obligation to notify the Motor Vehicle Bureau if the doctor can't or won't. And by the way, it varies by state. In the state of Maryland, believe it or not, I am not allowed to notify the Motor Vehicle Bureau because there's a confidentiality statute in Maryland, but there's no law that says I have to report people. So the legal counsel at the hospital says you can't violate the confidentiality law unless there's something that makes you do it. Now, I have colleagues who just call anonymously, and I don't know that that's right. But I can almost always get the family members to do it. And I have, on 2 occasions I can think of, reported people that I really thought were high risk and nobody was going to do anything. But why do we do that? What justifies? Again, it's because here the risk of harm is beyond that person. It's now society at large. Ultimately, it's the legislatures that determine these kinds of things, and they're as skittish as doctors and wanting to make these kinds of limitations on people's rights. But I think the principle here is we're starting now to see come up to decisions where other people, like living alone, if there's a serious fire risk, we have a greater obligation than if it's just the person themselves. Okay. How about the use of drugs and restraints to control behavior? Okay. There are a couple of facts. First, the drugs that we have that to treat the behavioral symptoms are minimally effective. All right. And in fact, the non-drug approaches, the kind of general things that I was talking about before, are as effective for behavioral problems as the drugs. Plus, the drugs have serious side effects, including death in people with dementia. Okay. So from a medical point of view, the obligation is to try everything you can that's reasonable before trying medications, with a few exceptions. If there's an acute danger or the person has a particular symptom that a drug might work for. Okay. How about physical restraints? Again, that is a very serious restraint on a person's freedom. And unless there is some kind of acute emergency, the person's running out into the street, they're leaping on people, they're pushing people. Physically restraining people is something we shouldn't be doing unless there's an absolutely very high risk of harm. But does that mean we never use the medications? No, because there are serious problems where people are being pushed, punched, hit. That's very different than accusing someone of stealing your money, where it might hurt your feelings as a caregiver, but that's not such really a serious risk. So unless there's a serious risk of harm to someone else or the ill person, we probably should not be using antipsychotic drugs. That still means that about 15% of people with dementia probably need to take these medications. So it's not a trivial or minor problem. But it does mean that as family members and as surrogates, whether it's legal or not, you should always be asked whether an antipsychotic medicine should be used, and you want to push the medical team to justify why it's being used and what limits they're going to put on its use, the shortest amount of time or the lowest possible dose. Okay. Now, how about lying to a person with dementia? Let me first take a vote. Who here thinks it's okay to lie to a person with dementia? Okay, about 20% of people say. Who thinks you should not lie to someone with dementia? Okay. So what does this mean? So someone who says, my mother's coming to get me at supposed to come get me at 3 o'clock, where is she? And 3 minutes later, where's my mother? When is she coming? And they get more and more upset and more agitated. And when you say to them, but Phyllis, you're 75. Your mother's been dead for 20 years. The person goes into an acute grief reaction, starts crying and weeping. Why didn't anybody tell me? That's horrible. And then a minute later, where's my mother? She's supposed to come get me. This is terrible. Let me out of here. So the person's very distressed. Everyone around them is getting up. Other residents, if it's outside a facility, or if it's at home, the family's getting very upset. So now the people who said you should never lie to someone, who thinks it's okay to say, your mom went to Panama City for the weekend, she'll be back on Monday? Think you should not say that? Who thinks you shouldn't say that? Still a couple people. Well, I think this is a tough one. Number one, some people say, well, that's not really lying. It's telling a white lie, it's a fib, you're just shaving the truth. I believe that's a lie. And number two, I believe it's a justifiable lie. So I have to defend it. Why? Because number one, as a society, we believe that truth-telling is a very important virtue. By the way, that's not every society in the world, which is it's hard for Americans for me to go to places where people don't tell the truth. That's just part of life. But that's not us. So we believe, by and large, as a culture, in truth-telling. Okay. The challenge here is that you have a disease that changes reality for a person, so that what we know, what we believe is true, for them cannot be true. That person cannot know that her mother is dead. That's number one. And number two, you learn from experience, so I think you have to try it, that when you do tell the person the truth, you harm them because you induce an acute grief reaction that is very distressing. But unfortunately, because they have dementia, they can't grieve, they can no longer grieve the death of their mother. So they're robbed of that ability to not just remember the fact, but to emotionally process it. So I believe in that circumstance, where in fact it's to the benefit of the person to lie, and it's due to dementia, it's due to a disease that has changed the reality, I believe it's justifiable, number one. Number two, I think it should be called a lie because we should feel bad about it. We don't want to do that. And it's not that we want to make ourselves feel bad, but we don't want to get on that slippery slope where everything then becomes a lie just to make it easier. We really want to think about it. One of the more extraordinary experiences I've had in my life where this sort of really came to me very vividly was I have consulted to a couple orders of nuns in the Baltimore area for a number of years. And, there are very few younger sisters. So now most of the individuals in the order are elderly people, the vast majority. And they have living facility, even though these are both community living orders. They've always had places where ill sisters would go and live, and these have evolved into licensed nursing homes, by and large. And of course, sisters get dementia just like everyone else. And so I had taken care of a few sisters for one order that has a monastery, beautiful monastery in a kind of remote part of Maryland, and we ended up needing to admit one of the sisters to the hospital because things were just so chaotic. Nothing was going right. We admitted her to the hospital for about 10 days, and she was ready to go back. We thought things were a little bit better, and I told them, and we decided, they agreed that I ought to come by in about 3 weeks, see her there, and I could meet with the other sisters. And so, and not so much to talk about this individual, but to talk about dementia because they were aging and they had a lot of questions. So I gave a little talk about dementia, and then we talked about some of the challenges. And then I brought up this issue, is it ever right to lie? And we went back and forth, and I sort of laid out my reasoning. And this particular sister that had been in the hospital was someone who had some ideas that were really distressing to her and everyone else, but that she could be distracted from by telling a story. And so I told them that was my opinion, and I'm walking back to my car, and the Mother Superior was walking me back to the car. She said, Dr. Rabins, thank you for driving all the way out here. I'm sure this was very helpful to all the sisters, particularly the part that you said about lying. And I said to her, I felt a little embarrassed because what's a Jewish doctor, is it really right for me to sort of tell people this of a different... She said, "Doctor, that was the most important thing. All that other stuff, that was interesting. That was important for us to get." And again, maybe these were just those individuals, but I feel uncomfortable doing it. I think we all do. But I think there are some circumstances where, in these kinds of diseases, that's the best thing for the person. And I think we should acknowledge that it's lying. And it's hard, and again, not everyone agrees. Okay. All right. And I don't think calling them white lies, face it, you're lying. Okay. How about the person with poor oral intake? So I want to talk a little bit about late stage and end of life care, because many of the really challenging aspects of dementia care come up later in the disease. And there are some symptoms of dementia. And by the way, I'm going to stop talking about Alzheimer's disease, because at the end of dementia, all the diseases are the same. When the brain isn't working totally, it doesn't matter whether it's Alzheimer's or vascular or Parkinson's. The brain isn't working, so most people share these problems. Okay. Most people have trouble walking, and they're falling all the time. For many people, again, think of infants. When they are born, they cannot stand up, right? They can't stand up till they're 6, 8, 9, 10 months old, because the wiring in the brain isn't completed. And in Alzheimer's disease and most other progressive dementias, eventually people lose the ability to be upright. Now, we are built to stand up once you get that ability. I can't, clowns can learn how to fall, but you can't even make yourself just fall over. But once that wiring becomes undone, you stand somebody up and they fall over like a tree. I mean, that's an unfortunate reality. And so many people become bedbound at the end of the disease, not because of bad care, but because that aspect of the brain isn't working. And many people become stiff or spastic. Okay. As I mentioned, many people develop trouble swallowing. Neurologically, they cannot swallow normally, and that means that food and normal secretions go into the lungs rather than down the swallowing tube, and people get pneumonia. One of the things that people rarely talk about is that the very last symptom of the inability to kind of recognize the world is actually an inability to move the eyes voluntarily and to look at people. So if any of you have taken care of or been involved with somebody with very late stage dementia, you walk up to them and they don't look at you. Now, if I were to walk up to any person in this room and say, "Now, I don't want you to look at me," and I walked up to you, it would be incredibly hard. We are wired as human beings to look at each other in the face, in the eyes. Now, people with autism may have a problem with that, but by and large, that's how we communicate. And our brain, just like it's wired to stand up, we're wired to look at each other. But at the end stage of dementia, perhaps in part because people don't recognize even faces any longer, just like a newborn, they don't look at us. And that's a real challenge for caregivers that we have to be aware of, because it's a very dehumanizing aspect. Because we relate. Now, sometimes you move down, you bend down, you catch their line of sight, and then they look at you. But you have to make that effort to do that. And I think it's useful to know that that's part of the disease. And then many people lose totally the end of the language problem. People become mute. They cannot express anything meaningfully. Or they hum, they make sounds, they cry, but they can't tell us they have pain, for example. What a challenge. Okay. So let me skip that. Okay. Well, one of the research things that I got interested in about 15 years ago was the whole question of people with dementia have quality of life. Because I believe as a doctor, in fact, the number one goal of medicine is to maximize an individual's quality of life as they define it. That's our goal. Now, for most people, how do you know their quality of life? You ask them, how's your life going? But again, because dementia impairs that communication ability, you can't ask many people, particularly with more severe disease, whether they're happy that day, whether things are going well or bad. But we developed this scale. There's a whole process of doing it, and we involved caregivers and patients and experts and all kinds of things. And we asked people, how do you know if someone's having a good or bad quality of life? And most people say, well, if somebody's crying, that probably means they're having a bad quality of life. If they're laughing or smiling, that looks like a good quality of life. We were able to come up with a number of items that almost everyone agreed were positive quality of life behaviors and were negative. Okay? And we developed this scale. That's not important. But what's really amazing is, so then we went out and we've used this, it's rated by people. And what we found is that even people with very severe dementia, very advanced, can have a measurable quality of life. And even at the end of the disease, people can have a positive quality of life, at least by this scale. Now, I think that's very important. So that tells us that good care in all stages of the disease, that's the target. Okay. We did another study, and I'll come back to it, in which we were very interested in how do surrogates make decisions for people at the end of life. And what we did was we identified 125 people, all of whom met hospice criteria for dementia. Okay, so that means, and Medicare used to have specific criteria for dementia, but essentially it meant people, the doctor thought they're likely to die within 6 months. We then followed these people every 3 months. We went through their medical records, we interviewed their caregivers and their doctors, nurses, and social workers. Now, some of them lived 4 years, by the way. The study only lasted 4 years. So that tells you, doctor, we're not good at predicting who's going to die, even in very advanced dementia. But one of the things we looked at was what decisions did the surrogate make for the family member? Okay, and we limited this analysis to 72 people died in the study, during the study. So we were able to look at the decisions that were made in the 6 months prior to death. Okay, so in the 6 months prior to death, half of family surrogates, mostly family members, but some of them were guardians appointed by the state because they were unbefriended people. Half had to decide, should we hospitalize the person? A third were asked for the first time, should we place a feeding tube in the person? I don't know if people can read this. I don't know if there's a way to blow it up on the side or not. Amazing. 5% of people were asked about surgery for the ill person. Now, what we found, next slide. There we go. Okay. What we looked at was we asked the families every 3 months then, and then after the person died, how hard was it for you to make, whatever the decision was, have blood work, go on a breathing machine, get a feeding tube. How hard was that for you as a surrogate to make that decision? And what we found, no matter what the decision, that whenever people said, yes, we're going to do what the doctors have asked, they were almost always, when they said yes, they almost always said that was an easy decision and I'm satisfied with that decision. However, when they decided not to do something, whatever it was, they were much more likely to say that was a hard decision, and they were much less likely to be satisfied with their decision. Okay? What is that? It's obvious. It's much harder for us to say, no, we're not going to do something than yes, no matter what it is. All right? So what should we do with that information? Well, I think that tells the professionals particularly something very important. A lot of the decisions that come up in people with very advanced dementia are tough medical decisions. And that while we can't tell people what to do, we can be supportive of their difficulty. Right? We shouldn't be rushing people to make hard decisions. We should not be telling people, you have to make a decision in the next 24 hours to put in a feeding tube. That's a huge decision. Now, I believe that should have been made months before. That should be discussed when people start having swallowing problems. But if it's not a medical emergency. And we have to realize that these decisions are hard for people. And we can support them emotionally in understanding that and making the decision. Okay? So that empathy, I think that's really important. And often medical practitioners, they sort of throw up their arm. You decide and let us know. No, I think we need to be saying, I know this is hard. We can talk about the pros and cons. I'm happy to listen to what you're struggling with. I think we can help surrogates make that. Now, just one or two other things in the study because I want to have questions. One of the solutions, of course, is to have advanced directives. And many people in our study had about 61% had an advanced directive. And it's important to keep in mind that it's not random who has advanced directives. Okay? So that in most studies, African Americans are much less likely to have advanced directives than whites, and this is often by choice. Okay. So this doesn't mean advanced directives are bad or they're not useful, but what it does mean is that when we look for some kind of technical legal decision, approach to making hard decisions, it helps some people but not everybody. And to think that if everybody would just have an advanced directive, there wouldn't be any hard decisions, that's ridiculous. It would help people. It might help people. But interestingly enough, when we looked at, remember we rated how hard was it for you to make a decision and how satisfied were you? The only decision that having an advanced directive made it easier for the family to decide was the feeding tube decision. All the other decisions, surgery, blood work, hospitalization, even when the person said, I do or I don't want this, the surrogates still struggled just as much. So advanced directives, I think, are important, and they tell people what somebody's wishes are when they're still able to express them, but they're not a solution that's going to make it easy to make these very hard decisions. And it comes down to the fact that these are tough decisions. Okay, I'm going to, I think, stop here. So let me just stop here and answer questions, and if there are any, and it's a different kind of subject than we talked about before, but yeah. Oh, let's wait. David's going to come up with the microphone here.
Good question.
All right, going back to the decision whether to force, I don't know if I like that word or not, maybe a conservatorship. So I'd like to have your opinion. If there are multiple 911 calls, APS has been in maybe 3 times, the local grocery store has had to call the police on a person with vascular dementia. They're locking themselves in the house. From the inside, deadbolts, and there's spoiled food. In your opinion, does that cross the line to being dangerous to themselves, that they're dangerous to others because of the driving, but a danger to themselves?
Well, so I think you've touched on all the important questions. So, number one, you want to have a formal, I believe, a medical evaluation of the person's capacities in some way. What are they able to do and what are they not able to do? At least from an expert, from a medical practitioner, psychologist, neuropsychologist, etc. Okay, I think when we're talking about abrogating, removing somebody's rights, I believe we need to have both legal and, it's my belief, a medical professional involved. Because, again, the default should be let that person be. So I think we want to have real evidence that they have a brain disease, and we want to have some medical assessment of that person's ability to make decisions. And neuropsychological testing can be very helpful in questionable cases in helping us decide, does this person have an impairment specifically in the ability to make decisions, to weigh pros and cons and make decisions? Okay, so that's number two. And then number three, as you touched on, I think, when do we, quote, force the issue? I think there has to be some clear evidence, myself, of danger or harm. The person's being financially taken advantage of. There are an unbelievable number of predators who are mailing and emailing all the time, trying to find somebody who, if they give a $10 donation today and 2 days from now they give another $10 donation, they're going to be getting an email every other day. And if they have dementia, that adds up very quickly. And they know what they're doing, and they're out there. That, to me, that's financial abuse and harm. And if there's no way to stop it, that would be evidence of harm. If they're not taking their medication, that would be harm. It's a little harder. They're going into the grocery store and they're causing a ruckus. Is the grocery store going to call the police? Are they going to face charges? To me, that's a harm. If they can't appreciate that what they're doing is wrong, to me, that would be evidence of a harm. Okay, they're still driving. They're walking away, and it's cold out. Somebody walks out tonight for 4 or 5 hours, and you're elderly, there's a good chance they could die. That's real harm. So I think you have to sort of have evidence that they have a brain disease, that they have significant incapacity in whatever the issue is. Often it's related to decisions, health or finances, and then evidence of harm. To me, that's when you need to get legal help, and that's when we involve the legal authorities. Again, if you can avoid that, that's the ideal. But if we're going to take someone's rights away, I think that's one of the admirable things about our culture. We're not going to take somebody's rights away just because we, as loved ones, think it's in their best interest. I mean, I'd love to hear people who disagree with that.
I want to go back to the feeding tube. I hope the day never comes that I have to make that decision for Priscilla. But I was told that with a feeding tube, you're not prolonging life, you're prolonging death. And I said, but I don't know that I would be able to sit there without a feeding tube and watch her starve to death. Mm-hmm. Then I was told they don't know they're hungry. The brain's not telling them they're hungry, so they're not starving to death. How do you feel about that?
Okay, let me tell you what I think the medical facts are and then where the decision lies. So, number one, many people develop impaired swallowing or an impaired drive to eat. They just won't eat. They'll clamp their lips shut. They won't eat. So that happens with the disease not infrequently. And when people start to have swallowing trouble, it may be another year or 18 months or even 2 years before they really start losing a lot of weight, but that means the problem is coming. And I think this is the kind of thing you want to discuss. If there are other people in the family who should be involved, you want to start having a discussion now. And it's the kids out of town who always want everything done, and the people in town who really know the situation, usually who are less on that side. Okay. Number two. There is no evidence that placing a feeding tube prolongs life or prevents pneumonia in people with dementia. So it doesn't prolong life. There is no evidence that it does that. Okay, so those are sort of the medical facts. Then words like starvation, of course, are very powerful. And even though the Supreme Court has decided that placing a feeding tube is no different than any other medical intervention, I think they got it wrong. Because we feed infants because they cannot do it. There is something about feeding that is so central to the human relationship that many people, not everybody, but many people feel that it is starving somebody who can eat, not to give them food. So this is harder than even should we give somebody antibiotics. That's hard enough. This doesn't seem to be a medical intervention to many people, even though that's what the Supreme Court said. Okay, so then how do we think about it? First, we can't know for sure what people with very advanced dementia are experiencing because they never come back. But there are people who have other medical conditions in which they become severely dehydrated and then recover. And they almost never say, boy, was I thirsty, was that painful, that was terrible. So, and we know from people who have chronic kidney disease and very gradually die of kidney failure, that in fact it seems to be true that getting gradually dehydrated and as all the chemicals build up that you're not excreting, it dulls the appetite. And if you look, I've been through this with many patients, people who are not taking in any fluid at the end stage don't look uncomfortable. If you go up and pinch them, they'll cry or scream or push their hand away. So I believe, as people have told you, I don't think it's an uncomfortable situation. It comes on very gradually. And the final thing is people, it's amazing. Those of us in the room here, just doing absolutely nothing. We need about 1,000 calories a day, 1,200 calories, maybe 800 if you're not doing much, to keep the machinery going. Our body's a machine. It needs energy. Okay. But if you have a very advanced dementia and you're lying in bed, the temperature's, kind of like in here, and you're not doing anything, you're not sweating, you don't need many calories. So people with very advanced dementia can get by on incredibly small numbers of calories. So if we want to feed somebody by mouth, and it might take an hour and they only get a little bit in, and that seems right, I think that, to me, that's something that can be done, and we should expect facilities, for example, to do that. But many people get to the point where, again, they clamp their mouth shut, they spit everything out. It's really painful for them to be fed. And I think then we have to think, so what are, the pros and the cons of the tube? So the tube goes through the wall of the abdomen and directly into the stomach. That's how people are fed. And that generally doesn't seem to be uncomfortable, although some people pull the tube out. It's, you have a surgical site there, or you have a tube there. That doesn't seem to be uncomfortable, but there's no evidence that it prolongs life. So again, my feeling is this is a decision for the family and the surrogate. Many people have expressed a wish in their advance directive, and I think that should be followed. But the truth is, in the end, the surrogate is making that decision based on, what the person has said. And the challenge is that we all can change our advance directive anytime we want. And research is very clear that about 50% of people, of cognitively normal people, who become sick change their advance directive when they become sick, and the vast majority of people change it in the direction of wanting more, not less intervention. Now again, these are general data, okay? So, but I think the important point is that people do change their mind. The trouble with the thing in dementia is they can't change their mind any longer because they're not able to, so they're relying on us. So I think the ideal situation is if you appoint a surrogate who you feel knows you best. You tell that person, here are my general feelings and thoughts, and I trust you to make the right decision and the decision maybe that I would make if I knew all the facts at that time. I'm not a lawyer. There's a saying in law, bad cases make bad precedents. The same thing is true sort of in medicine. It's the facts of individual situations where you make these tough decisions. And so, yes, it's hard. And I don't think it's right to say put in a tube or it's right to say not to. I think you have that choice. But it's like all these decisions, I think you do the best you can. You realize it's hard. You talk to people about how hard it is. And you make that decision in what you think is, in this case, her best interest. And even, it's coming out of love and respect for that person. But it's going to be tough either way. And now, when there's disagreement, that's a challenge. And I will say this, because I was on the hospital ethics committee for 20 years, and the most common issue is disagreement, either between the medical team and the family or within the family. And our experience was 70 or 80% of the time, once everybody knows the facts and they're given time to talk about it, they come to some decision. Okay? And it may be that not everyone's happy, but the kids from out of town say, Billy's the person who's involved the most. I totally disagree, but I'm going to defer. 20% of the time, you can't get an agreement, and ultimately you have to go to court, and I think, again, that's the right thing. But most of the time, even though it's hard, people can work these things out. But it's a struggle, and we shouldn't think that it's going to be easy just having written down on a piece of paper or having a doctor tell you what's the right or wrong thing to do. I think we struggle with these things because we care about the person, we love them, and they're the hardest decisions in life to make. And that's the basis, I think, of all of this surrogate decision-making once somebody is identified. We hope that they'll do the best that can be done in tough circumstances. Well, so I am going to stick around. I'm happy to sign books. I answer questions. Lunch is 40 minutes, an hour and something.
Question here.
In here?
Do we have a question?
Yeah.
Oh, a question? Okay.
Yeah, and my question is,
I'll keep going, by the way. So.
You're talking about lying.
Yeah.
Well, this lady's 94, and she wanted to see her mama, and I told her mama was in heaven, and she said, "Oh yeah, that's right." So sometimes I'm completely against lying. So I think it's probably the way I was raised. But
by the way, I'm completely against lying too.
yeah,
And I hope my children are truth tellers. And as you said, the first thing you do is tell the person the truth. The second thing you do it the second time. But once you realize that when you tell her mother's in heaven and she starts getting very distressed, okay,
Yeah.
and that happens in many cases,
Yeah.
then it's the wrong thing. You did the right thing. I think we start with truth-telling. But the reality of this disease is many people, they can't understand that.
yeah.
They get very agitated. You're lying to me. She won't come see me. She doesn't love me anymore. And then again, that's harmful. So we want to tell the truth, but then we want to avoid harm if we can. But I'm not saying you're wrong and I'm wrong. I'm just saying this is the way I've sort of worked this out for myself, because this is something I face all the time. I think we should tell people they have Alzheimer's disease. But in my office, when I sit down and sit down for the first time with the person, I've evaluated them, and I say, I'm very concerned that you have a serious problem with your memory. And they say, Dr. Rabins, I don't know what you're talking about. There is nothing wrong with me. Mm-hmm. And I say, Ms. Jones, I'm sorry, but we've done the test. It looks like you're having some problem. Doctor, I don't know what you're talking about. I do not have anything wrong with me. I stop. Because that says, and I don't know that this is right, that says to me, they either do not want to know, which is their right, or they cannot understand it. Now, if they come back again, I usually try once more. But if somebody can't appreciate it, again, that's my truth, that's the family's truth, that is not there. They can no longer, they can't understand that. So that is not the truth for them. And why beat that into them? That seems cruel, and actually it seems wrong to me, but I'm not saying I know all here. This is very tough.
I have another question.
Yeah, please.
This lady can tell you everything in the past,
Yeah.
and we can talk about it, and she'll answer, and it's right, but she can't tell you anything about what's now. Like last night, I talked to her, I passed the phone to my husband, and he answered the phone, and she said, "How is Ann?" I had just talked to her, so you're right about that.
Yeah, but
Thank you.
again, but there's think of it. There's a positive. When I started out, there was a senior psychiatrist who had written an article, and the title of it, "What Do I Say to My Mother When I Have Nothing to Say?" And he talked about the fact that he was very devoted to he would go and visit her every day in the nursing home, and he'd been doing this for many months, and he was just having the same conversation day after day, and it was getting really hard for him to repeat it. And then he finally realized that was his problem, that she loved her son visiting. And the point was they were having a conversation, and he could tell about the grandkids or talk about sports or religion, whatever, the family, all kinds. And as long as they talked about old things, she was happy. And that was the purpose of going. It wasn't to make him happy. It wasn't to make her learn who got married. It was to make her happy. And once you realize that we're there for that ill person, it really, for some people, not that it's easy to have the same conversation every day, but it's great that they can have a conversation at that level. And you can reminisce about when you went on vacation together 30 years ago. And, wasn't it fun, or wasn't it funny when it snowed in August in Glacier National Park and we weren't ready? And you can have a great laugh about it. And they're still as much a person as they ever were.
Hi. Can we talk about competency for a sec?
Sure.
And clarify, if someone's making a choice, how do we know that they understand the choice? Do they have to repeat it, or how do you know that they understand?
Yeah, that's kind of hard. It's a great question. Hard. Again, I'm a pretty basic person. So I believe that at a minimum, they have to restate the problem and say what they want to do. Now, so if they can't, now again, it's finessed here. What if, again, they say, the doctor wants to cut my leg off and I don't want it. I'd say, well, you got to tell me a little more. I'm not sure you understand what might go wrong. And we're going to have to go to a judge if you can't do that. So again, if they're able to say, I could die if I don't get it cut off, or maybe it'll just fall off by itself, which, by the way, is true. This is a case where the doctors and nurses get freaked out, but a lot of people survive. It's their ignorance. You got to know the medical facts. So at a minimum, the person has to be able to say, this is what the issue is, and I think this is what I want to do. Again, I think we are weighing the greater the risk, the more we expect from the person. I think that seems right to me. So if the decision is, I'm not taking a bath today, not much harm there. Okay. I'm never taking a bath. Well, that's unsanitary, but how about a sponge bath, or what's in between? I think there are lots of decisions that people make big deals about that aren't. And again, when it's like that, I think we let the person go. So I don't know if it's hard, but I think they have to be able to repeat the issue, and ideally repeat at least tell you one or two of the options.
Further issue of justifying that decision is not one that you require.
I don't require, again, the more they can justify it, even if it's a stupid reason, but if it's consonant, the better I feel that they're making a decision. Okay. And I'm lucky it's not up to me. It's ultimately up to a judge or whatever. But I'm willing then to state the reason I think they are or are not. And the other thing is, again, if it's not an immediate emergent situation, I believe they should be reassessed, ideally 2 more times, but at least once more. So there are other things. So consistency supports the idea that it's a choice. So if today they want something, 2 days later they want it, and a week later they want it, that at least supports the idea that it is their wish. If 2 days from now they say the opposite, that's inconsistent, and that would go against their making any kind of a meaningful choice. So that's listed, I think, on one of the slides. But that is the crux of the issue, I think, and it's not easy. Again, so where testing helps is because testing can assess the general ability to make decisions, if you will, to weigh pros and cons about things that are not necessarily emotionally laden. Often these have a lot of emotion in them, and so people have strong feelings. But if we know that somebody has a severe impairment in the ability to choose, and in fact they're choosing at random things based on the testing, that would be against their having the capacity to make a decision that has a serious financial or health outcome.
Time for maybe 1 or 2 more questions.
I have 2 questions that are kind of not related. I've always been told that you can't die of dementia. You don't die of Alzheimer's. You concur with that? It's
No.
something, okay.
If you stop eating, that's dying of dementia. It's about 60% of people die from pneumonia.
Yeah.
They get pneumonia because the swallowing apparatus is impaired due to the dementia. As far as I'm concerned, the dementia caused, the proximal cause of death might have been pneumonia, but they got pneumonia primarily because they couldn't swallow. And that's true whether it's ALS and you're cognitively normal, or Alzheimer's and you're not normal. So I believe you can die from dementia.
Okay. The other question is, in Georgia, we have a POLST. Do you have that in Maryland? So, you know what POLST
Well,
is?
but why don't you explain it?
Well, okay. So POLST is a advance directive with a medical signature. So I would come and sit down with you, and I would say to you, my wishes are, I don't want to be resuscitated, I don't want a feeding tube, blah, blah, blah. And you have a copy of that, where you may not have a copy of my advance directive. So I just want to know, in the state of Maryland, is that electronic? Can it go from place to place, or does each individual have to have one? Because here, it's not like electronic. If I was to go to the hospital here, nobody would know that I have a pulse. So I'm just wondering, for my own benefit.
As far as I know, it's not electronic in Maryland. This is purely me. I think the ideal situation is if there is somebody you trust, you have a conversation with them and tell them your values. So here's the issue. Sometimes if you go into acute respiratory failure and you go on a respirator for 24 hours, you have a 95% chance of surviving and of getting off the respirator. There are other people who, if they have COPD, chronic obstructive pulmonary disease, and they go on a ventilator, their likelihood of ever getting off of it forever is 20 or 25%. That's a very different decision. And, if you were getting sick and I had a few minutes to explain that to you, you could decide. But that can never be in any document. So that's the challenge, I think. Even what is artificial feeding? What is that? Is having an IV that only gives you fluid, is that feeding? Well, I think you'll get people to give different. There's sugar in that. There's glucose in that. Now, can you get enough calories to live forever? No. But if they put a catheter in your vein and give you high calorie, yes, you can. So, to me, the ideal is to say, look, if I have a very advanced disease and I don't know what's going on, I wouldn't want to live that way. And I would much rather, if I got pneumonia or I stopped eating, I would rather not be put on IVs. I'd rather not be sent to the hospital. I'd like to have a natural death. And then, so if you're lucky to have somebody that can understand your values, I think then, if that's not available, then I think these forms are better than nothing, way better than nothing. But it's the details of often of every situation. There's a difference between getting an antibiotic for a bladder infection that hurts and getting an antibiotic for pneumonia that might save your life. Well, I mean, there's a million of these shades here. And again, if you're lucky, if you can say, well, you know, I think my kids could all make this decision. I'm going to ask my middle daughter if she'll be willing to do it because she's closest and that's the ideal thing. But you're right. I think that there are all these other technical challenges. How does it go with you to the hospital? And do you paste it on your refrigerator? So when the EMTs come, they always look in the refrigerator. So that's good, and that's better than nothing. But it's so tough, and it's the reality of surrogacy, and there are bad situations, and there are many good ones where it goes right, but there are lots of bad ones, unfortunately.
I was just wondering, on the plaques and the tangles, once that has begun and someone's determined to have Alzheimer's, is there anything you can do, or do you feel there is anything that's done to slow that or progress that, or is that just basically set in motion and it's just going to happen on the timing that that person has?
Well, you've asked a $100 million question. I'll answer it. And by the way, again, I'm going to give this other talk in Cartersville, and I'm going to talk a lot more about those kinds of questions. So here's what we know now. First, it appears that the plaques begin they are deposited in the brain 15 to 20 years before the first symptoms of the disease. Okay. So again, there's a lot of evidence to support that. Number two, those plaques are what's left over when brain cells die. Okay. So that plaque, remember there's a purple circle and there were black dots around it. So the purple circle is a protein called the beta amyloid protein, and the black dots around it are the pieces of nerve cells that have died. The reason I say it's such an important question is, so number one is, once cells die, can they regrow in the brain? And interestingly enough, for the past 100 years, people have said no. We now know that in the memory part of the brain, the hippocampus, in fact, we are making new nerve cells all through life, even in late life. So it is possible that if we could stop the disease in its tracks, that the memory part of the brain might keep functioning, might improve over time. But the whole brain is involved. The disease starts in that memory area, but then spreads. So if it's already if symptoms develop and it's 20 years into it, cells are dying everywhere. And right now, the likelihood that all these other cells can be replaced is zero. Now, this is why people talk about stem cells and all other kinds of things as possibilities. But most people in the field think, we don't know what makes cells in the brain connect to one another in the right way. It's impossible to think of how that might happen. So it could well be that if we developed a treatment that stopped the disease, okay, that you might be stuck at that point forever. That's one possibility. So really what people are now thinking is, we're going to have to identify when the disease starts, 15 years before symptoms. That means in people's 50s and 60s, 40s, and 50s really. And is that going to mean you have to take something forever? Are these powerful drugs? It's a very important question. But most people think now that by the time you have symptoms, a treatment not only might not do anything, but the disease the damage might have a life of its own. Does that make sense? Because what happens, again, sorry to go on some, this amyloid protein is in the membrane of every cell in our brain, every neuron in the brain. So it's a normal protein. And when the cell dies, the protein, this amyloid protein, just gets deposited in the brain. The body thinks that's not supposed to be there, and it attacks it as a foreign body. Okay. Now what happens, and it secretes all these chemicals that to kill bad things that shouldn't be there. So what do those chemicals do? They kill other cells. So it's like a cascade, right? You kill one cell, and that makes more die, and then more cells die. Well, they secrete. So it's as if so one possibility is once it gets started, the treatments might not keep up or might not be able to stop that cascade. Now, all this could be wrong, but these are some of the challenges of coming up with a treatment and why they're trying to figure out how to do trials in people with very, very early disease or even before they become symptomatic. And that's where most experts think the future lies in treatment. It's prevention, really. So it's like why do we take high blood pressure medicine and cholesterol-lowering drugs? We take them to prevent stroke and heart attack. That's the bad outcome. I mean, it's not that blood pressure in itself is bad. I mean, it's that high blood pressure predisposes you to stroke and heart attack, so we lower your blood pressure and it lowers your risk. And so this would be the same kind of a treatment that we could identify people who are genetically vulnerable or just starting to have the cells die, and that's who would we be treating so they never got the disease. How close are we to that? I don't think anyone can answer that. You know, there might be a real breakthrough in 5 years. It might be 50. That's the hard part about science is you really don't know. I mean, the truth is that all the things, that the things that are being most emphasized now are 10 years old, and maybe they're now trying to give these drugs to people before they have symptoms rather than during the disease. But so far they failed. So I'm an optimist in a way, but I think this could be a long time before there's a prevention, a good prevention. But again, let me remember, just to finish on this. Remember I mentioned before, midlife high blood pressure, diabetes, high cholesterol, being overweight, all the things that are risk factors for brain vascular, those, and I didn't say before, by the way, exercise, which seems to be somewhat preventive. If you add all those things together, I think we probably can do something to lower the risk now.